this is kind of the stump the chump. I mean, I really want you to think about the things that are frustrating for you, that you've always wanted to know. And I will say emergency medicine, addiction medicine, pain medicine, neuropsych, and ortho. We'll call those all on limit. So we'll just add that one. I'm probably going to fail miserably at the ortho. I know enough to be dangerous in the ER. Put bone back in place. But then call ortho to screw bone back in place. That's how that works. But so feel free. I mean, ask. I mean, these are things that are really complex, and many times a lot of these things end up in a whole bunch of different spaces. And so I'm happy to, including business stuff. So like MBA kind of stuff, you can ask me the question.
So I read, or I understand that gabapentin is the second most commonly found drug in people who overdose on opiates. And
well, benzos is, gabapentin's third to fifth, depending on the region, but yeah.
So why do you think that is? And what's the abuse potential of gabapentin? Why do opiate addicts seem to love gabapentin?
Well, I love gabapentin because it's alcohol. I mean, that's basically the way in which it works. You know, on the gabapentinoids, even though they don't work directly on GABA like the name would say, it works within the same realm and it does the same basic stuff. So my long-term alcohol use disordered patients, because gabapentin is actually an emerging but pretty well-studied treatment for a chronic alcohol use disorder to decrease the number of drinks per day and the number of drinking episodes per month. So we know that it does that. It also works really well for alcohol withdrawal, which tells me that it crosses over really well with the pathway for alcohol. In fact, you can use that as a monotherapy for mild alcohol withdrawal, just gabapentin. And so the reason that it's liked for people who are still not in remission, who are still in active addiction, is because it is a boosting agent for everything. Meaning, if I take 300 of gabapentin and I smoke a J, I'm going to get super high. If I take 300 of gabapentin and I drink a fifth, I'm going to get really drunk. Or I won't have to drink a fifth and I'll have some for tomorrow. I mean, this is just the reality. This is what I'm told from all my, my patients. And it makes sense because gabapentin works in a number of different places in the brain. It just makes it more susceptible to crank dopamine up a little bit. It's like a primer drug. Just like marijuana is a really good primer drug as well. If somebody's smoking low levels of marijuana, it takes less alcohol to get drunk, which is why we find the combination of alcohol and marijuana in Colorado causing a significant increase in car accidents and motor vehicle deaths, because people drink a very little bit, but they're smoking weed, and so they get really intoxicated, much more than they would predict based on the 1 or 2 glasses that they had. And it's the same thing for gabapentin. It is, and so here's the problem, is we say, no opioids, no opioids, no opioids, and they're like, what do I do? Gabapentin, because it's the next thing and it's cheap and we can give it for pain. It only works for neuropathic pain, and it really only works for specific subtypes of neuropathic pain. It's a crappy mood stabilizer unless you're actually adding it on to a true mood stabilizer. And it really is only something that can be helpful for patients who are mood disordered and have an alcohol use disorder for chronic use, from what I've found. So it is high risk, and it's one of those things that's probably going to move up on the schedule. Right now it's Schedule 4. It's probably going to go to Schedule, it's already moved to Schedule 3 in some states. But federally it's probably going to move to Schedule 3, so that we're going to have to write a prescription that requires more oversight. And it'll be basically controlled the same way buprenorphine is. You won't have to get a G license for it, for gabapentin, but you're gonna, you'll have to, take the same precautions when you prescribe it as you would the other. All right. Yeah. Yeah, so the question is what does naltrexone do to turn off alcohol, since it works in the opioid axis? So there are no good deep neurological studies, so I'll give you my theory on this. So this is my neuro theory. So you have a GABA channel and an opioid channel that both modulate anxiety, sleep, hunger, happiness. We all have those 2 different ones. This is why benzos can make some people happy. That's why some people can take an opioid and be like, this is awesome, and not really be sedated with it. But why some people can be sedated with an opioid, but like super happy without alprazolam. And so you're either kind of a GABA heavy brain, meaning your mood is more modified by GABA, or an opioid heavy brain, where your mood is more modified by your opioid side. Some people are balanced, but most people are not. I don't know many balanced people in my world. But when we look at this, if you block opioids, what you're doing is you're taking away one of those pathways that has the highest chance of sending off a message to the lateral habenula, which is that default pathway for behavior. So there's a direct connection. So when you block that dopamine bump from thinking about it, because you don't have to use a substance to get intoxicated from it, by the way, if you have addiction. Early in addiction, you can get intoxicated by thinking about it. I mean, this is a functional MRI stuff on this is crazy. So people will, and we saw this in those MRI studies on the ones that we looked at for 6 months and 12 months. So just thinking about the use of the substance and that preparation phase for obtaining the substance, you can get intoxicated. Not as much as using the substance, but about 70%. Because the brain has a memory of that and it feels super happy. And so this is part of what it does, is it blocks that ramping up, because that is more opioid controlled through the ventral tegmental and the nucleus accumbens. So when you block that, you don't get that rapid ramp of that preparatory dopamine release, and so you're less likely to set off the lateral habenula, making your default behavior to be to use. So that's where I think it works. Some people will say, well, naltrexone decreases craving. I disagree with that statement because I have no data to show that. Some patients will say that, but I think that it's not a necessary day-to-day craving. I think it decreases their craving because they have less risk of that cue-associated relapse craving. Meaning, I saw a beer and I have to have a beer. Or I saw somebody using and I'm like, I have to use, because it blocks that one piece of the signal. It's effective for the right people, meaning it's probably directly genetically related about who's going to do well with naltrexone, because there are some studies emerging where you have single nucleotide polymorphisms that show that it's ineffective. It's just, you're going to get a 0-0. And this is the allele, little l, and anyway, we don't dig into that. But as we look at that, I mean, ultimately what you're looking at is, we're probably going to find an indicator of who's going to be good for this for alcohol. Maybe down the road we'll find out who's going to be good for this for opioids. We're still a little all over the place for the genetic indicators for that. But for alcohol, it's a little bit of a we should try it pathway for that, because it may be a light switch like you've seen it. I've seen this in my most recalcitrant, homeless, violent alcoholics who just didn't drink. We were able to keep them housed. And then they would relapse only because they were just pissed that they couldn't drink. And they would just relapse because they just wanted to relapse. It wasn't an accident. It was a decision that they had made because they were bored and they hated this and they wanted to use. And so, yeah, it could be really good. So in my opinion, do I think addiction is hereditary? I don't have to give opinion on this. I can say that we have good research to show that it is hereditary from a genetic standpoint. About 60% of the causative agent is that. It's also hereditarily evolved from epigenetics. So let me explain that really quick. If I am dumped into an environment with famine, my body will change the way that my DNA works so that I metabolize food differently, so that my hunger cues are different, so that I'm more motivated to go and get certain types of food and do certain things. It will decrease my overall metabolic rate, so I'll have a little less energy, so I'm not burning through what I have. That all takes place in what we call epigenetics, meaning I get a little carbon, methylation on one piece, I get a little bit of a change in the acetylation of another piece, and it just changes the way that my body turns the DNA into protein, right? And protein, as we know, turns into receptors or turns into molecules. And so that epigenetic change we used to think was only relegated to the person themselves. However, what we have found is that we can actually inherit epigenetic changes. And we can inherit them 7 generations later. So the studies are pretty creepy. So we used to think that we would just say, does your mom or dad have any issues with alcohol or drugs? If the answer, or your siblings, and if the answer is no, we're like, all right, the genetic component's probably okay. But what we need to ask is, did your parents, your grandparents, your great-grandparents, your great-great-grandparents, your great-great-great-grandparents, your great-great-great-grandparents have an issue? And if they did, then you're still at risk. because the epigenetic changes actually go down. Now they dilute over time, so it becomes less and less, but it still adds to it, which was so stunning for me when I first heard about the 7 generations pathway for people in the Native American population teaching forward, how intuitive that was and how it actually matched the genetic studies for what we find as the heritability of this. So there's really interesting pieces to it. So yes, there's absolutely a genetic component. If you look at, my family's probably a good case, right? So you look at all of my grandparents died from addiction-related illness. I had my last memory of my grandfather. He was a bomber pilot in World War II in Korea, but he was a hardcore alcoholic. And my last memory of him was on the steps of the VA. He was bright orange from liver failure. I didn't recognize this. I was 12. I didn't know any of this stuff. I just knew Grandpa looked bad, and I was like, "Why do you have a weird tan?" And that was the last I ever saw him. That was the last conversation I had with him. He died. His wife died of throat cancer from smoking and drinking, all of those things. And then on the other side, I had my grandmother die of premature coronary artery disease and carotid artery disease, and she stroked out at 54 with like horrible arteries. And then my grandfather died of COPD, asthma, and lung cancer not too long after that. So all addiction related. And I didn't see it as that. I was like, Grandpa had COPD. He died of addiction. Let's just be honest. COPD was the thing that we saw at the end of it. But if he hadn't smoked, then he would look just like my dad, who's 75, takes 0 medications, works out 5 days a week, and still works full time. Because my brothers smoke cigarettes, and I'm the oldest brother, and again, we go down to you're 43. It's kind of what my brothers look like. So there's a lot of factors that go into saying it's genetic, but it's genetic plus. And the answer is at this point, because people all have some genetic contact with somebody who has addiction somewhere in their family, we just have to recognize that everybody's at risk given a certain set of circumstances. And maybe if they didn't have early life trauma or that sexual assault, they wouldn't have addiction. Maybe if they hadn't had a domestic violence relationship, they wouldn't have addiction. Maybe if their family didn't die in a car accident, they wouldn't have addiction. Maybe if they didn't fail out of medical school and have a bunch of debt and couldn't be a doctor, they wouldn't have addiction. There's a lot of these things that happen, and we want to say somebody's got low risk. Nobody's no risk. And a lot of it is the genetics and epigenetics, and the fact that addiction is just a part of humanity. This is just a reality, which gets me to kind of the stigma thing that I think is important. The stigma of addiction is about anger. It's not about like HIV, where it was about fear. A lot of you aren't old enough to be around when HIV came out, but I was a paramedic at the time in the early 90s when HIV was out there. We didn't really know it. We didn't really understand it. We didn't know how it was really contracted. It was scary as hell, to be out there, because you're like trauma scenes and you're extricating people out of vehicles and you got blood all over you. It used to be like, I got blood all over me. Now it's like HIV, and you're like, oh my God, it's really scary. And we didn't understand it, and so when we saw that somebody had HIV, it's a them. And I'm happy that it's them because I can know that I'm not a them. And so we stigmatized them out of fear. And happiness that we're not a them because it doesn't affect me. Right? And that's kind of what happened there. But what happened with addiction, in my mind, and I've had deep conversations with a lot of people who work in the medical field, and why they are so uncaring toward people with addiction. And what I have really come to believe is that every single person who has a reluctance to treat addiction, who's pushing really hard against it, has had a very direct relationship with addiction. They have had a parent, they've had a brother, they've had a sister, they've had a best friend, they've had themselves, and they have been hurt by somebody with addiction, and they are angry at them. And they are mean about it because they think that they did it, they made a choice to be an addict, and because of that, they're angry and mean, and they have all of this transference and countertransference that occurs toward them. And it's less about fear and just not understanding, and it's more about anger. And so as we start to look at the genetics, it's interesting because quite honestly, all of us are in the same position. Whether we chose to see it as us being hurt by the person with addiction or just having to be a part of it is a little bit of semantics for some people. And so as we start to look at how we build protective communities for this is all about teaching resilience early. And the data is really clear that the best thing that we can do, everybody always asks me, what can I do to make sure my kid doesn't become an addict? I don't want to go to the moon. But the data is really clear on this, that the one thing that's been shown to effectively and consistently decrease the chances of someone becoming addicted, especially in adolescence, is deep resilience training for those kids. And that deep resilience training, there are methodologies for doing that. It's not a theory, it's actually, there are things. It should just be what's taught in schools. We should teach mindfulness, motivational interviewing, and resilience before anybody ever learns 2 + 2. I mean, honestly, it's just, this is where we have to go with this. And I think it's even more important in a population that has generational trauma. And we were talking about this last night at dinner, and how deep and how recent the generational trauma is with the tribal nations in California. And I had really no idea that, how pervasive it was, and really how the depth of kind of traumatic destruction that occurred to this community in the 30s and 40s. Most of us, think you read the history books and, it's cowboys and Indians, it's back in the 1800s, and we see the movies and we're like, yeah, it was horrible, and you hear Trail of Tears, and you go through all of this, but the reality is here locally, it was a double whammy because that happened. We had, all of this stuff from the national government where they're hunting them down and putting them on reservations, but then it happened again, where people were actually conscripted into the military, and then their kids were removed from their house and put into boarding schools. And some of these boarding schools may have been okay, but the vast majority were not. And it was very traumatic. They deculturated them systematically by basically making them not ever speak their language, not practice their culture, not be connected to it in any way. And in doing so, that's generation 1 of that significant trauma and the epigenetic changes that occurred. They're still alive. So in order to clear that, we have to have 7 more generations that die. It's not birth. It's as the generations completely matriculate out. So we're in the middle, and really kind of the beginning of working through a very traumatic experience, and then figuring out how we move through the first phase of kind of this trauma pathway, which is learning to actually trust other people. And that may be people in your own circle, it may be people in your community, it may be people from outside of your community, and how you work together with them. And I can't imagine after hearing this and reading this how you would ever gain trust people like that out of the community and that. So this is a really amazing opportunity, as horrible as it is, this opioid crisis, to kind of bring a lot of these pieces together as we build this system. And we don't build a system for opioid use disorder, but we build a system for really a trauma-informed community approach to addiction treatment and prevention. And if we do that, but you guys are working on that, and if we do that, then what we're going to have is a place that recognizes early trauma and steps in. Not after it's already really occurred to a deep way, right? But we don't step in and say, I'm putting you in jail. I'm stepping in and putting you in therapy. And I'm going to get you some time to get stable for this. And whether that therapy is, just a deeper connection to the tribal history and the connection with the community that's there, or if it's directed trauma-informed CBT, whatever works. But all of those systems need to be available in here. And as we start to build this out methodically, I definitely don't want you to take from this that, well, we just got to add MAT. I mean, that is a small piece. Yeah, we have to do that. It is evidence-based, it decreases the risk of death, and improves the chances of somebody surviving and doing well. All of this other stuff has to happen.
Thank you for the opportunity to ask. I look at our audience, and there's a handful of us that will be prescribers, there's a handful of us that will be counselors. And so my question for you is, you have the luxury of running a clinic that is staffed and built around managing this very difficult population of people who've had all this trauma. Can you share your thoughts on the impact that the rest of us can have as we engage these patients who heretofore have been the ones that we've written a contract based on how quickly we're going to be able to get rid of you, as opposed to, I'm here, I understand, let me help you get to where you need to be.
Yeah, this is a 10 or 15-year project. I mean, I want it to be a 2-year project. I want us to go out and build all of this stuff, but this is reality. It took us 40 years to build cardiology, to where we have all of these different things, and we have the capacity to identify this, to fly you where you need to go, to intervene and do a heart cath, or get you a bypass, or put an LVAD. It took a lot of time for that. We're going to compress that down to a third of the time because we have a lot of money pouring in, and if we do it thoughtfully, then what we can do is build that future state system. But the current state, there are a lot of things that can be done. And we've talked a little bit about these. The first one is make sure that every opportunity that you have, that these people know that you have their back. I'll give you an example in the emergency department. So I still work clinically in the emergency department. I work at locums, so I end up in places that I don't know any of the structure. I just show up and I work a shift and do a few of those shifts a month. And I've worked at a bunch of different places with that. So I'll walk in and I will use buprenorphine in the emergency department, and I've written a lot of prescriptions. By the way, first shift I could do it at every place. One call to pharmacy, it's in the Pyxis, and I say, I'm going to be writing this, I have an X-waiver, here's my license. If I see a patient, I will be writing this, and they're like, okay. There was no P&T committee, there was no 15 people getting in a room talking about it. I'm just going to do what the FDA has said that I can do, which is first line scope of practice, and do it. But not mean, just like, hey, just to let you know, I'll probably write this. Can you let me know what form you have and how I can use it? Right? So it's pretty easy to do, low threshold. So that's a basic thing. Is those that can, should. That's a big piece. The second one is, if the person doesn't want care at that moment, which is about half of the people or more in the emergency department at the time, there's a lot of stuff going on in their lives, they got reversed on naltrexone, they're freaking out, not everybody's going to want help right there. But what you can say to them is you can give them a handful of clean needles and you can give them some fresh cotton and you can say, look, I'm worried about you and I got your back and I care about you. That's it. That's all I got to say. That basic little piece, half the time, and I'll tell them, by the way, I'm here tomorrow, so if you change your mind, feel free to pop in. Half of them would show back up. So it's that little piece. They just need, remember we talked about hope and hopelessness being those transition points? All it takes is that little piece, and it takes that little piece to happen in the smallest places. In just a primary care clinic when somebody's showing up to just get their blood pressure checked. Right? L&D, first time. You don't even have to ask. The way that I ask somebody in the obstetrician's office and the way that I teach my obstetricians and FPs to ask the question is, so my job is to evaluate all of the things that are very risky, that can happen in pregnancy, and we want to make sure that we have the best chance of you delivering a happy, healthy baby and everybody going home. Do we agree with that? They always say, yes, of course I agree with that. So to do that, what I want to do is make sure that we've evaluated all of the possible risks that we can intervene on and identify what is in. Is that okay with you if I ask questions about that? Yes. I just want to say, some of them are a little uncomfortable, but I ask them of everybody, so I just want to make sure that you're cool with it. Is we still okay? Universally, yes. And then you ask, do you smoke tobacco? Yes, no. And then you go through your screening. You ask your screening in that empathetic tone, you look them in the eye, and you walk through it. Your standardized, screening tool. And if there's hesitation, or if they say no, but you get a weird feeling, then your answer to them after that is like, good, we're done with that. I know that was probably uncomfortable, and I appreciate it. Just to know, sometimes during pregnancy, things change. Happy to take care of you no matter what happens. The faster we know, the faster we can make sure that you have everything you need. That is different than, you don't drink, do you? Those are very different things. And so it has to do with how you interact and how you do it. Making sure that administrators understand this, making sure that the people at the front desk understand this, making sure that people outside of healthcare understand this. Right? Teaching the community about the fact that a mother on MAT is a success story. Bravo! We identified it, we treated it with evidence-based treatment, we're more likely to have a nice, happy baby and a family that goes home. Awesome. Give that reward to the people who've done a good job. So, we do this for people all the time with other diseases, like cancer, right? We create support groups, we give them pats on the back, we push them, and we tell them they're doing a great job. What's the number one cause of cancer? Smoking. What's the second largest cause of cancer? Alcohol. Third largest cause of cancer. Morbid obesity. So glucose in a subset of the population pumps dopamine no differently than heroin. So in the end, all of the stuff that we sit around and do fun runs for and do all of these things are really the aftermath of addiction most of the time. It's not all the time. Nobody's asking for cancer. But you know what? The number one cause of cancer is an addiction-related illness. And we never really mention that. We never bring up the causative actions that can be there. And quite honestly, when a patient is identified with cancer, we don't care. We just treat them. We just identify that they have an illness that's super sad and frustrating and limits their life, and what we want to do is do the best that we can to treat them. But if we would have been braver earlier to have a human conversation with a person in a way that is sensitive to their culture and their history, about addiction or just misuse a little bit. Maybe it's just use that's a little bit rough right now. Maybe it's just the way that they're not seeing the world that's in a good place and they just need another pathway. Those are the very concrete things, is a culture from the top down within a healthcare system that just says, we are here to support our people. We are here to support them no matter what. It's going to suck sometimes. It's going to be really hard. You're going to get yelled at sometimes. There's going to be paperwork sometimes. There's going to be frustration sometimes. But if you do the right thing for a patient, I have your back. Because I knew that you had the patient's back. It is that culture of a community that makes the biggest difference. And if you don't have that, no matter what buildings you build or what treatment pathways you come up with or what shiny things that you have, it's still not going to work as a community. And so we have to just get past the point that the disease of addiction is a bad decision with immoral people and move to the point that we recognize that it's a genetically predisposed chronic neurobiological disorder that nobody wants. But when they have it, we need to treat it aggressively and consistently. That's the best thing that we can do right now until we transition to the fiscally capable, sustainable system that we know we can have. And we build it out just methodically, step by step. You identify your biggest gap that's going to decrease your mortality. You build that first. You're doing that. You're building MAT capacity. That's your biggest one. Your second one, you want to build out the different levels of care, not that are culturally competent, but that are culturally relevant, meaning that they are they've been built as a part of the culture. You want a level 2.1 and 2.5 on the reservation. You want it to be fully compartmentalized inside of this. And then you want people to feel like they have other people they can talk to. So if they're pregnant, that they have someone. If they have co-occurring disorder, that we're really looking at it and getting it. So we'll get there. But that's my best answer for that, is that I think that there are a lot of small things that we can do, but most of it is about really meeting people where they are and understanding that addiction is a chronic neurobiological disorder that nobody woke up in the morning and said, please give me this. Yeah.
I just wanted to touch on I recognize that we've gone through this huge opioid crisis, and yes, the pendulum swung so far that everybody got overprescribed.
Yep.
And I'm just seeing now that I follow up a lot of people in our OER, and now I'm seeing that there's now this culture of everybody's an opioid seeker. We're seeing this pendulum swinging the other way.
Mm-hmm.
And now I'm seeing people getting underprescribed. I'm
Yeah.
seeing people like, well, I had really cracked ribs and I got some Tylenol. How are we going to start treating people who really have pain? I'm now looking at some people and going, gosh, I hope nothing ever happens to me, because how am I ever going to get treated for pain?
Yeah.
Where are we going to go now when you have real pain? What's going to happen?
Yeah, so the question is, what do we do with people who have real pain because the pendulum has swung so far in one direction that we're not giving anybody anything? I mean, there are entire primary care practices who just say, I'm not writing any opioids, period. So, two quick things on this. One, there are no data that show that chronic utilization for chronic non-cancer pain is helpful longer than about 6 to 8 weeks. And in fact, the optimal time frame to utilize opioids for things like broken ribs is 3 to 4 days. And then the utilization of Tylenol or ibuprofen actually is equivalent to opioids in pain relief and outcome when it's in blinded prospective studies. So, knowing that the opioids are not the answer, I'll give a personal example. So I have a herniated L4-5. And it's ruptured into the foramen, and that occurred last August when I was running. So I was out running, I slipped off the side of the bank, went down with my leg fully straight, about 4 feet, landed just like that. And it hurt, but it wasn't horrible right then. The next day, I just couldn't move, man. I was stuck. So our tendency would be to identify that and give that opioids. The data would show that that would be the worst possible thing I could do for function. And the best possible thing that I could do is use an anti-inflammatory, identify the localization of the deficit, get an MRI to determine if we need to do surgery or if it's something that can be rehabilitated, and then go from there. So that's what I did. I took ibuprofen, Tylenol, hung upside down in my house a little bit, to try to do anything that I could do to offload it. But I had radicular pain, it was burning, consistent, it wasn't going away, so I went to my primary and got an MRI. And this was frustrating for me because I used to be the chief of pain medicine in the health system, but I just moved to a town that I had never lived in, so I didn't have any direct connections in the health system there, so I felt very much like an outsider. And so I had to just call my primary, who's been out of his residency for 2 years, and try to explain I have this horrible back pain without sounding like I'm asking for meds, because I just need an MRI. But I called and talked. We said, well, I need to have an appointment. I was like, all right, fine. So we go in and we have an appointment, and we walk through it. He does a good exam. We have a conversation, and lo and behold, before I said anything, he goes, we have good data that shows that it's probably not a good idea to use opioids in this situation. And I stopped him and I go, wait a second. That's the best freaking answer I've heard from a primary care doctor. Because I had never even told him who I was. I hadn't had my annual yet. This was like an initial visit that I squeezed myself into without ever having a full visit. And so with this, I got an MRI, had this. I got 2, as you saw earlier, lumbar spine steroid injections. The first one didn't work. It gave me about 8 hours of relief, which is the lidocaine doing something, but nothing else. I went to physical therapy, and I was continually doing physical therapy, still having no relief, no real pain, no change in symptoms. I made an appointment with a surgeon, but we decided with my PM&R doc that I was seeing with this to just continue to get another injection and try it, and then and continue physical therapy. And this was now January of this year, so I started in August, so it took a while, right? It's not immediate. And the next injection worked really well. It's the right place, it bathed it perfectly, the pain dissolved, so we went really aggressive with physical therapy during that time, with just McKinsey physical therapy, which is you find the pain of comfort, you continually go back there and you do that, and I'm running again, 6 miles, whatever, and with no pain and no ridiculous stuff. I have back pain, but it's not horrible and it's non-surgical yet. At some point it may be, and so the moral of that story ultimately is, that's not the American way to wait 9 months before your back pain is better and you can exercise again. And so we have to change the theory of what we think about pain. And we have to just have a realistic understanding that pain is pain and suffering is separate. Suffering is how we interpret the pain and how our emotional contextual reality interprets that pain, and it gives us a signal. A lot of people go very rapidly to suffering because their life's not great and they have pain. And so when they have that pain, it turns into more of a catastrophe than just pain. And so helping people to tease apart what is pain, because pain is just pain, it doesn't have to be suffering. We can work on suffering separately. That's where CBT, I do mindfulness just as a regular kind of normal day thing. I do at least 1 body scan a day, and it's really helpful. And so I just upped my number of times during the day that I would do mindfulness, anytime that it was hurting, anytime I was sitting for a long time like on an airplane or whatever. And I got 0 pain right now. It's probably going to hurt later when I finish my drive to Reno later tonight, but that's the thing. So I think what we have to do is make sure that what we don't do is accidentally swing the pendulum back too far to use opioids. Opioids are amazing if you have a life-limiting illness. I will bathe you in oxycodone if you are in palliative or hospice care. I will, if you have a femur fracture or a kidney stone, I'm going to light you up. I'm gonna make sure that I will get you right to the point where I might need to breathe for you, because I want your pain to be taken care of. And I think that's perfectly fine. What I won't do is write you for a month of opioids. That's where the problem happened. And I think we're learning that now. We're having a lot of conversations in the emergency department. Ortho and surgery are following behind on these conversations, but they're happening. And that early, high-intensity treatment of pain without continuation is where it's at. So that high intensity, like if you had those rib fractures, Ketorolac, if that didn't work, you treat it really aggressively for 2 to 3 days with opioids, as long as it's safe for that person. But we need to ask, any history of addiction, any history of risk. I mean, these are all things that we miss out on, because that could be a trigger for people to be like, I broke ribs, I got 2 Norco, and now I'm shooting heroin. I mean, these are things that we have to think about. There's a lot of risks that go with it other than iatrogenic addiction. So the big piece is we will find a balance. We're not there yet, to your point. We're going to start back where we were, which is doing a good job with palliative and hospice care. And then we're going to move into the next phase of this, of identifying what is the standard of care for acute treatment of a new injury and post-operative pain? And I think we're going to find, and the data already sits on this, that it's 5 to 7 days at the most, 3 days for an acute non-significant trauma, 5 days for a significant trauma, femur fracture, 3 to 5 days, shoulder surgery, 3 to 5 days. All the data shows that it's equivalent to or better than for outcomes, risk. Because think about if you're covering up pain and you're trying to heal. You're just causing micro trauma because we're covering up the pain that you need to have to say, don't do this, after shoulder surgery. So there's a lot of these things that we're finding. We have higher failure rates in surgery with more opiates. So I think what we're going to find is that we add on the therapies that we know work. Mindfulness-based therapies, which is the most efficient behavioral therapy that we can give, and is better than any medication, and it works long-term, and I'm pretty sure you can't overdose on it. You might get a little, like, oh man, but you're generally not going to OD on it. And I think that's where we're going to go. That's where I hope we go. That's where I hope. And I think those of us in the pain world, especially the education side, are really trying to push that modality of multimodal pain treatment using opioids only when either everything else has failed and function is in the toilet, or short-term, high-intensity early to get people in the right space so that they can then use things like ibuprofen or Tylenol moving forward. And then adding on all of these other therapies, and we've gotten the payers to now start paying for it, and that's a big piece.